Good morning. My name is Jenny Nakhan. I am a family nurse practitioner. I work at Aurora Healthcare. I've been in dermatology for the last 14 years. Yep. I guest lectured in your health assessment course for the procedures, and I'm here today to talk to you about dermatology, focusing on adult. You'll have pediatric dermatology in another semester. Just to remind you, I am certified in dermatology. There are subspecialty certifications. That's the DCNP that you see after my name. So today what we are going to talk about are some common skin problems that you see in primary care. So we'll talk about viral eruptions, eczematous rashes, drug rashes. We will also discuss psoriasis, fungal infections, insect and bug bites, skin infections, acne, some benign skin lesions, as well as skin cancer. So today I hope to give you some basic information about these conditions, as well as some differential diagnoses and how to treat these common skin problems. So we're going to kind of go back to the basics here and talk a little bit about what you do when somebody comes in presenting with a dermatology problem. It's really important that you can describe what you're seeing. So when somebody comes in, you're going to get their medical history, their HPI using your old card, and then you're going to do your physical exam. So with a skin exam, you're going to be looking for some specific things, and the first thing you're going to look at is the primary lesion. And the primary lesion is typically the first lesion that appears. Then you will start to look at some secondary changes of the skin, making note of the color of the rash and the surrounding skin, arrangement of the rash, and distribution of what you're looking at. So primary skin lesions. This is so important that the terms that you use in your physical exam assessment are the appropriate terms. So macule is used often. That is a flat lesion. So if you run your hand right across the skin, you don't feel any raise. That is usually less than 1 centimeter in size. A papule is also less than 1 centimeter in size, but it's raised. So if you run your hand across it, your hand actually raises up a little bit. A plaque is a solid flat top lesion, and it's usually 1 centimeter or larger. That's when the papules form together, they coalesce, and they become a plaque. A nodule is a raised solid lesion. It has indistinct borders with a deep palpable portion. So if you push on it, you can just feel it go down in the skin there. Typically, these are larger than 1 centimeter. And a wheal is an area of tense edema, so it's slightly raised and flat topped as well. Secondary skin lesions. So this is what's occurring around that spot, and that is erosions and oozing. Oh, I'm sorry, I had, was it? Oh, I'm sorry, yeah, that must have skipped out of here. Okay, I apologize for that. My slides messed around a little bit. Other primary skin lesions. So vesicle, which is a raised clear fluid-filled lesion, and that is less than 1 centimeter. A bullae is the same, but it is larger than 1 centimeter. A cyst is a raised lesion that has a palpable sac with solid material in there. And the photo on the left is a picture of a cyst. You can see the black dot that's right in the center of that lesion, and that is the hallmark sign of a cyst. That's an open punctum that's right there. So if you're not sure if a lesion is a cyst, always take a look for that black spot. Kind of looks like a blackhead right in the center of the cyst there. And then a pustule is a raised lesion filled with a fluid exudate. It usually has a yellow appearance. A lot of people remember that for pustules, kind of filled with pus. It's not a clear liquid that's in there. So now we will go to our secondary skin changes. So I have briefly talked about this earlier. So erosions and oozing, you'll have some crusting of the skin and some lesions, scaling, sometimes atrophy, excoriation. So that's usually just from scratching when somebody's really been irritating the skin. Fissures can occur, ulcers, and scarring. So more description. You can't describe these rashes and lesions enough in that physical exam. So we want to know, what color is it? And then if it is more than one lesion, you want to describe the distribution of it. Is it linear? Is it annual, meaning it's in a circular arrangement? Are the lesions grouped? Are they discrete, where they are very distinct and separate? And also along with the distribution, is it generalized or localized? And this is just a photo of herpes zoster following that dermatome. So now that we know how to describe our skin rashes, we're going to go and talk a little bit about viral eruptions that you can see in primary care. So some that we're going to discuss today are herpes, both the simplex and the zoster. We'll briefly mention varicella, but that's really discussed in your pediatric derm. Molluscum, warts, and viral exanthem. So herpes. In general, herpes, it's just a virus. And viruses in this group include the varicella zoster virus, herpes simplex 1, herpes simplex 2, cytomegalovirus, Epstein-Barr virus, and other human herpes virus strains, which are infrequently seen. And in fact, working in dermatology, I don't think I've seen other herpes virus strains. So herpes simplex, we'll start with that one. The herpes simplex virus 1 in the past has always been the most common cause for the oral labial herpes. And the herpes simplex virus 2 is the most common cause of genital herpes. Now we're not seeing so much of that. You can have either herpes simplex virus 1 or 2 in any location. You are not going to know just by looking at it. The only way you are going to know what it is to culture it. And a viral culture is something that we do recommend. So it's nice for the patient to know, it's nice for you to know. It's just a cotton swab, so you open up a little blister when they come in. Looks like a Q-tip, you just swab it and send it to the lab for viral culture, usually a PCR. So the herpes simplex virus can be classified as their first episode or recurrent episodes. But really, it's unusual to see somebody in the office for their very first episode of a herpes simplex infection. It comes a few times before they realize what's going on and they seek treatment for it. So a hallmark sign, and I have it bold-faced here, for herpes simplex is typically patients will experience a prodrome of burning, tingling, or itching that occurs before they have an outbreak. So a lot of times people will know it's coming once they realize they have herpes. They'll start to feel some pain, itching, burning in that area before they get the skin eruption. So the oral labial herpes is triggered by UVB radiation. Treatment for it is acyclovir cream, not the ointment, which is unusual. In dermatology, we typically love ointments except for herpes, of the oral labial herpes, where we like the acyclovir cream. Valacyclovir, or Valtrex is the brand name, is something that came out a few years ago. It works very well for cold sores. You can take 2 grams at the onset of symptoms. So as soon as they would feel the burning, tingling, itching, they would take 2 grams and you repeat it 12 hours later. And usually that's enough to stop the outbreak. But the longer they wait to take that pill, the more likely it is that eruption is going to occur.
When you say UVB radiation, is that sun
Just
or
sun.
weather?
Yep,
Sun?
just sun. The UVB radiation. And I mean, if somebody's doing indoor tanning, that would also be a trigger to it.
And when you said, the sooner the better, is there a time when you would not prescribe it if they've had it for 5 days, or do you still give it for, just because?
Yeah, a really good question. If it's been there for longer than 24 hours, we typically, the skin lesion itself has been present for 24 hours, and we typically don't treat. At least with the valacyclovir, they could still use the acyclovir cream, but probably not going to get much benefit at that point. So for genital herpes, really important that you remember there is a huge psychological component to that. Treatments for that can be episodic, and I have the episodic treatments listed here, which include the antivirals. If somebody is having a lot of outbreaks, we can do suppressive therapy as well, where they take a lower dose daily to hopefully help prevent those outbreaks. More and more of the research, we used to say that as long as they didn't have sores, they weren't contagious, and now we know that that's not necessarily true, that even when they don't have sores, they could be spreading the genital herpes. So suppressive therapy is a much lower dose. The acyclovir at 400 milligrams twice a day, 800 milligrams a day. The valacyclovir, 500 milligrams daily. You can push that up to 1 gram daily if 500 is not enough to keep their herpes under control, or the famiciclovir as well. So herpes zoster, this is caused by reactivation of the chickenpox virus, and that remains latent in our nervous system. Age and immunosuppression do appear to be factors in it, but we can see herpes zoster in any age group, not just in older adults, although the incidence does increase with age. And Caucasians are at higher risk for herpes zoster than other ethnic groups. It usually is unilateral and it follows a dermatome. Patients typically do have pain prior to the eruption starting. They'll notice itching, pain, discomfort, and then papules and plaques will occur, and they occur on an erythematous base. These papules and plaques can sometimes also have vesicles in the area. The lesions occur for several days. They can become hemorrhagic, necrotic, or bullous. Younger patients tend to get over this quicker, 2 to 3 weeks, where older adults can keep it for up to 6 weeks before it goes away. So treatment of herpes zoster is rest and then antiviral therapy. Now for the herpes zoster, we say typically within 72 hours. There is no value in treating after 72 hours, and so we would not give an antiviral. I know that depending on where you get treated, some people will give an antiviral after 72 hours, but it really provides no benefit to the patient. Again, you can culture this for a definitive diagnosis, and we always do culture it. It's a painless test. It's relatively inexpensive, and then you have your definitive diagnosis. People can develop the post-herpetic neuralgia, which is the worst part of herpes zoster. They can have pain, extreme pain, for up to 18 months after having herpes zoster. So we are strong proponents of the shingles vaccine, and we discuss that with all of our patients who are over the age of 50. So the shingles vaccine is an interesting vaccine because coverage hasn't always been so good on that. Patients really have to check with their insurance companies because typically Medicare covers it if they get it at the pharmacy, but they don't cover it if they get it in the physician's office. And it can be a couple $100, so it's really worth it for the patient to just check it out with their local pharmacy, how much it would cost, or call their insurance company. So the FDA has the shingles vaccine approved for age 50 and older, but the CDC does not have recommendations until somebody is 60 years old or older. So again, that patients have to be real aware of their insurance plan and what they're going to cover. Some insurances now are starting to cover from the age of 50.
I think I have heard sometimes with shingles that people give steroids and other medications to prevent that post-herpetic Is there any evidence that says anything else would help?
No, and actually no good evidence that the steroids are helpful either, outside of just helping to heal skin lesions. That can help, but we don't prescribe it. And if there is any question of eye involvement, if it's near the eye, we recommend referring to ophthalmology for further evaluation. And you can get shingles more than once, so even if somebody has had shingles, we still recommend the vaccine, because some people will come in and they're confused about that. They said they've already had it, they're not going to get it again. That's not true. The chickenpox virus is in the nervous system, so they can get it again. So varicella, I just had brought up a picture here. This is discussed in the pediatric derm lecture. So molluscum, we do touch on this in the pediatric derm lecture as well, but we do see it in adults, so I wanted to mention it here. In the bottom corner are some great pictures of molluscum. They are smooth, dome-shaped papules, and you can see in the center here, they're umbilicated, right in the center of these spots. So when you see that umbilication, that's really a diagnostic of molluscum. So the size of them can range anywhere from 2 to 5 millimeters. Sometimes people will develop a dermatitis around the lesion, where the skin that is flat, so surrounding this umbilicated raised papules, some secondary changes we would call them, would be redness, peeling, dryness. The skin sometimes is excoriated. That's a good sign when people get dermatitis around the area, because it shows your immune system is trying to fight that virus. These spots are commonly secondarily infected from scratching. So when you are looking at somebody with molluscum, always keep in mind that they can become infected. If you do think there's a possibility of infection, to take a bacterial culture and see what's going on there. So in adults, we see this because it is sexually transmitted. So we can see them on the inner thighs, mons pubis, scrotum, and even on the penis, they can develop them. People typically have less than 20 lesions at a time unless they are immunocompromised. So it's caused by a virus, the MCV1 to MCV4. We already discussed the sexually active adults. I mentioned immunocompromised people are more at risk for molluscum, and young children are also more at risk for it. So molluscum, you do not have to treat molluscum. They will go away on their own. They can last sometimes a year and a half to even 2 years before they go away. So people sometimes are confused about that. And if they decide they want to have spots treated, you have to make sure that they realize you are just treating the spots that are there. That doesn't prevent new spots from coming. When you treat these spots, you also have a risk of scarring. If you don't treat them, they will go away and heal with no scar at all. So just to make sure that your patient or your patient's parents are aware of that before you would treat the lesions. And typically, molluscum are treated either with cryosurgery, so liquid nitrogen, or topical cantharone. Some offices have that, some don't. Cantharone is a liquid. It is a form of beetle juice that comes from South America. I don't know how they ever figured it works well, but it does work well for molluscum. The really nice thing is it's not painful. So you apply it right to the lesion. They leave it on for a couple hours, and then they just wash off with soap and water. Both the cryosurgery and the cantharone will eventually blister and scab. They'll look worse for a week or so. I just had actually 2 women in their 50s that had come in with molluscum. Both of them were very nervous about this. They were concerned that their partners were unfaithful, that this is a sexually transmitted disease. We had lots of reassurance to them. It was interesting to me, though, because the person they saw before told them they cannot have any sexual activity until all the lesions are gone, or they will continue to spread it back and forth between their partner and themselves. That is not accurate information. They both have it inside them. It's a virus. It doesn't matter. They got it from their partner. They both have lesions. They do not need to abstain from sexual activity. So we'll move on to warts then. There are more than 100 types of HPV, very, very common skin infection. Depending on where the wart is, depends on the name of it. So Verunca vulgaris is the term for common wart. Verunca plana is flat wart. Verunca plantaris is when it is on the bottom of the foot. And then condyloma acuminata is genital warts. So with warts, what our goal is when patients come in with it is to destroy the skin that the wart is living in. That's really the only way to get rid of the wart. So again, lots of patient education that when they come in for this wart treatment, things are going to look worse for a week or two, then things should start to heal, and then we see them back. We treat every 3 to 6 weeks until the wart is gone. So it's really important up front that the patient knows that this is not a one-time and done deal. There is no wart treatment that is one and done. Treatment could cause scarring. So if somebody comes in with warts on their face, you need to be very careful of the treatment that you're recommending. And if you're doing cryosurgery, you want to be really light with the liquid nitrogen. You can always treat more if you need to at different appointments, but if you treat real hard on that first appointment where you cause scarring, that scarring is going to be permanent. So now I did list some wart treatments. Cryosurgery is typically what's done in primary care office, so that can be done with the cryosurgery, the spray, the cryac, or with the dipstick where you touch it right to the wart. So we discussed that during the procedures workshop. I did mention cantharone for the molluscum, that's the beetle juice. That can also be used for warts. Imiquimod is a really nice option that the patients do at home. So you actually don't do any treatment in the office. You give them a prescription for imiquimod. That is the generic version of it that originally came out to treat genital warts, but we have found it works really well for any type of wart. If you do prescribe imiquimod, I just always give patient education that they will see a whole bunch about genital warts in that little pamphlet if they open it up. So just make sure that you give them that education. If you're still having trouble treating the warts, they just aren't going away, then dermatology referral is very appropriate. And in dermatology offices, then we can do laser destruction, candida antigen, bleomycin, which is some chemotherapy that actually gets injected right into the wart. So viral exanthem, this is another rash that is discussed more in the pediatric lecture. The viral exanthems are much more common in children, but I did just show a few photos here. So we will move on to our eczematous rashes, which is a lot of what you see. So we'll talk about atopic dermatitis, the irritant and allergic contact dermatitis, seborrheic dermatitis, as well as stasis dermatitis. So atopic dermatitis, this is localized erythematous, scaly, oh, I'm sorry, I have a typo in there, papular, exudative, or lichenified plaques. So that's a lot of descriptive terms in there. Not all dermatitis has all of that. It can be any part of that description up there. So we do talk about this in the pediatric derm lecture, but it looks a little different in adults. So I just wanted to mention that here, that it has less characteristic distribution. So a lot of times in kids, we see it in the antecubital spaces, behind their knees. But in adults, we can see chronic hand eczema, dry skin. Sometimes it's just all over. They're just itchy, dry. They can have thickening of the skin, and that's what I mentioned here, that they may have lichenification of the skin, where it kind of looks like elephant skin, where it's just been going on for years. They've been scratching at this area. They can be slightly dry, elevated papules as well. I recently had a patient in who was being treated for psoriasis, and he came in with dry papules just over the extensor surface of the elbows. And if you ran your hand across it, it just felt like sandpaper. It was so dry. It wasn't psoriasis, it was some atopic dermatitis. So they can be excoriated. because of the scratching, watch out for staph. These areas can get infected. They will not get better unless you treat the infection. And the patient that I mentioned who had the papules on the elbows, it can be a little bit tricky sometimes because the papules can join and form plaques, which can look similar to psoriasis. So the atopic dermatitis, I love this photo. You can see that lichenified skin behind the knee. You can see it in front of the knee. This patient has had atopic dermatitis, not treated well for many years. So it's worse with, sometimes with heat or stress, worse during the evening, the itch, and we don't know why that is. That has been looked into, that if you just aren't as busy in the evening, when you sit down and also you're thinking about it more, or if something physiologically is happening that causes the itching to be worse at night. Stress is huge with a lot of skin conditions, and we definitely see that with atopic derm. So causes. There are many causes. We do know that atopic derm is becoming more and more prevalent. There seems to be a genetic component, there's environmental factors, and really interesting, it is more common in higher socioeconomic groups. We don't know if that's maybe because more products are used, is there some more stress going on, we're just really unsure of why that is. So adolescents, I just wanted to mention them as well. So they have the classic antecubital and popliteal fossa, so right behind the knee, front and side of the neck, forehead, the periorbital area, so right above the eyelid, right below the eyelid, people will get that. In adolescence, we typically can tell them it's going to get better over time, and they usually will outgrow it. In our adults that have the atopic derm, usually it's a lifelong condition then that typically does not go away. They will have periods where it's better or worse, but it's usually never completely gone. So some differential diagnoses for atopic dermatitis are seborrheic dermatitis, if it's occurring on the scalp and the face, an irritant or allergic contact dermatitis, nummular dermatitis, psoriasis, and I had mentioned some of the characteristics that were the same with psoriasis, and scabies can sometimes look like atopic dermatitis. So some ways to treat it. You want to avoid temperature extremes. So sometimes people will go in the shower and they'll turn it as hot as they can, and they say that feels so good when they're in the shower, and then they come out and it just worsens it. So they should take lukewarm showers. In Wisconsin, the winter is very dry, the heat is on, and we see the atopic dermatitis get worse then. So we recommend running humidifiers. Manage stress. I always laugh when I see that, because if we could do that, that would be wonderful. Patients a lot of times laugh at you and you tell them that. So other things to do are just to be real mindful of what's going on in your skin. So we recommend mild soap. Dove Sensitive Skin Soap is a bar soap. It's inexpensive. That is the #1 soap that we recommend. We do not recommend baby products, and patients will come in and they say they're using their baby shampoo and baby lotions. They are typically heavily perfumed, and they have colors added to them that make them look nicer, all things that can irritate the skin. And patients will really need to hydrate their skin daily. So Cetaphil cream and CeraVe cream are 2 of the most common creams that we recommend. Very few people are allergic to it. I have seen a few people allergic to Cetaphil. I have not seen anybody allergic to CeraVe cream. Both are widely available. Eucerin's out there, but we see a little bit more trouble with the Eucerin with some preservatives that are in there. So other things, they are using a mild soap, they are moisturizing every day. Then we start giving some prescription treatment. So typically it's topical corticosteroids. Ointments are better than creams. Patients will complain a little bit about the ointments. They're greasy, they can stain their sheets, but they just work better. Again, there's less preservatives in those ointments. So triamcinolone 0.1% is what we prescribe for the face, under their arms, and in their genital areas. I've had some patients call me back when I prescribe that, and they'll say, my pharmacist told me I cannot use this on my face. Yes, they can use it on their face. We do it all the time. It works very well for limited amounts of time. So typically we say twice a day, and they can use it for up to 2 weeks safely in any area. Now for the extremities and the trunk, then we go with higher dose steroids, fluocinolone or clobetasol ointment, just depending on their pharmacy coverage, their insurance coverage of those medications. Just either one work very well. What we started having patients do, especially on the legs, is they'll put on their ointment and then they'll layer Cetaphil or CeraVe right over the top of it. And it gets them in that routine of using their moisturizer. So after 2 weeks, they'll pull away the top of the steroid, but they're going to continue with that moisturizer every day. So very severe cases, we do give oral steroids for that. So prednisone tapers are what we use, but for skin conditions, you need to give a little longer than the Medrol dose packs, because with Medrol dose packs, it's a nice burst, but it's only for a few days, and they will, as soon as you're done with that dose pack, they're going to flare. It's going to be even worse than it was before they came in. So typically what we do is we give a 15-day taper, which I know sounds really long, but it works very well. So we give 60 milligrams for 5 days, 40 milligrams for 5 days, and 20 milligrams for 5 days. It's really important that you discuss with patient possible side effects of the prednisone, make sure they're appropriate candidates for that as well. Now this does work really well. We limit how much prednisone we will give a patient every year to 3 courses in 1 year. If they are needing it more than that, then we need to do something else for them because we're not getting to the cause of it. Oral antihistamines can work really well. Just over-the-counter Zyrtec or Claritin, it can cut down on itch. Antibiotics for secondary infections. The one thing I didn't mention in here was laundry detergents. You want to make sure that they are using some gentle laundry detergents, free and clear laundry detergents. All is what we recommend most often. Yep, all free and clear. Tide has come up with a free and clear, but that still we have found has been irritating to people's skin. We stay away from the baby laundry detergents as well because of fragrances, and we don't recommend any fabric softener. If somebody insists on fabric softener, bounce free as a dryer sheet, that's the only one that we recommend at this time. But just something to think about because their skin is coming into contact with their clothes, which are washed in that, their sheets, their towels, everything. So contact dermatitis. There are 2 different types. There's irritant, which is an inflammatory reaction, and that's due to exposure to something that will cause an eruption in most people. So it's not really an allergy, it's just that you got something on you that irritated your skin, and most people would react that same way. Or allergic contact dermatitis. And this is acquired sensitivity to substances. It's an inflammatory reaction. You have to be sensitized to it. You typically don't react the first time that you are exposed to that product. So things that can cause irritant dermatitis are soaps, detergents, bleaches, acid. An allergic contact dermatitis is something that has come into contact with your skin. So most common allergens, you see it here in Wisconsin during the summer months, the poison ivy, oak, sumac, nickel, which is in our jewelry, in the back of the buttons of your jeans, balsam of Peru, which is a fragrance that a lot of people can become sensitive to, neomycin, so in the topical, the over-the-counter antibacterial ointments like polysporin, neosporin, bacitracin, just see more and more allergies to that. We never recommend any of the over-the-counter triple antibiotic ointments. Other fragrances, thimerosal, preservatives, we discussed the bacitracin, and rubber. I actually had a very interesting patient who had a terrible allergic contact dermatitis on his backside and the back of his arms. We had figured out what it was. He was allergic to an ingredient that was in his recliner, in the stuffing of the recliner. And so he kept reacting there. It was also found in his car seat. So he now has to have specific cars without that preservative in it. But anything you can become allergic to. And Also, people will come in and say, I've used this product for so many years. I haven't changed anything. You can develop a new allergy at any point. But the other thing is they can change ingredient lists and the labeling stays the same. So you would never know a new ingredient was added to that same product. So for allergic contact dermatitis, we sometimes recommend patch testing, and that is done actually at a specialty dermatology office. We don't do it at our office anymore, but they actually tape different products to patients' back. There's a standard tray that has 80 different products that get taped onto their back. They go back to the office 2 days later, the products are removed, they see if there's any reaction, and then they return to the office 5 days later for a final reading. So that test can run up to $4,000. They cannot shower during that week that they have the patch testing done. They cannot work out. Anything that causes excessive sweating can impact the test. About 60% of the time, we will find what they're allergic to with that patch test. So the patients need to be told that before they're referred for patch testing. For 40%, we aren't going to find it. But if we do find it, we can get rid of it if we know what's causing it. So before we would send somebody for patch testing, if they're just coming in for their first time, that you're suspecting an allergic contact dermatitis, we treat with topical steroids. So the same that we use for the atopic dermatitis. There are so many topical steroids out there. You are going to get comfortable with a few and just kind of keep reusing those few. Lots of times it's the clinic that you're working at, your preceptor, what they like, you tend to like. The triamcinolone, the 0.1% ointment again for the face, under the arms, if people are having reaction to their deodorant, the triamcinolone is very safe to use there. Fluocinolone ointment is great for the body. We again can give the oral prednisone taper, and I have it listed out here, the dosing. So where they are reacting can sometimes give you clues as to what's going on. If they're reacting on their head, behind their ears, in the back of the neck here, lots of times that's their shampoo that they're using or their conditioner. So really just take a look. Their wrists, fingers, could be a nickel allergy. On their hands, something that's getting on there. If it's just on their lips, sometimes we have seen people with allergic contact dermatitis, like a woman who's now allergic to her husband's aftershave because she kisses him and she gets that on her lips or in the brain area. So we'll talk a little bit about the poison ivy, oak, and sumac. This typically appears within 48 hours of exposure to a sensitized person. So that meaning that the first time you come in contact with poison ivy, oak, or sumac, you're likely not going to react. In fact, you will not react. But the second time you're exposed and the third time, then you will start reacting. It is due to the oil that's found in these plants called urushiol. Some ways to help is if you think you've been in contact with poison ivy, oak, or sumac, wash things off as soon as you can. Soap and water wash. That will help to get the oil off of you, which will stop the spreading. That oil can get onto clothes, shoes, gloves. So let's say one day you were out weeding flowers and you got that urushiol on your gardening gloves. You put them away, you took them out 3 weeks later, put them on again, you touched them to put them on. Guess what? Your hands were just exposed. It can be on animal fur. And I just had a patient in a few weeks, well, it was probably about a month ago now, and she said she knows what poison ivy looks like. She did not get into it. It was all on her hands. And when I was talking to her further, her dog had been out running around in some weeds, and she was petting the dog. So the dogs can really spread it. Can be on golf clubs, weed eaters, fishing poles. So anything that you're suspecting might have been exposed needs to get washed with soap and water. Hunting gear being put away for 6 months, it still will be active when you get that out in 6 months. So with poison ivy, oak, and sumac, the lesions are in a linear distribution. It's from where that leaf touches you. So when you see a line of a rash with the blisters, you need to have this on your list of differentials. So the vesicles or blisters are present. Sometimes people will actually get a black dot. I have not seen a black dot eruption, but if you Google that, it is discussed if there is a black dot with it. that is real significant for poison ivy open sumac. So common places, backs of fingers, in between the fingers, wrists, eyelids, ankles, forearms, lower legs. And this photo kind of shows you here these lines that are happening. It can last 2 to 3 weeks if untreated. So even if somebody doesn't get treatment, it will eventually go away, but it can take 2 to 3 weeks. When we see somebody with it, we typically treat them with our steroids, the prednisone, because it's very itchy, it's very uncomfortable. It gets worse before it gets better. The 60-40-20 for the 15-day taper. And then we also give some topical steroids. People's eruptions that they get from poison ivy just depends on how allergic they are. It's not always how much they've been into contact with it, because if you're very sensitive, you could have minimal contact, but be pretty broken out. One other thing is people will sometimes burn it in a bonfire, not realizing they have poison ivy in there, and I have seen somebody react on their face from that being burned, and it was a terrible reaction that she had. So seborrheic dermatitis, we'll move into a new dermatitis. This occurs in 2 to 5% of people. It's a chronic superficial inflammatory disease. It is scaling on an erythematous face, and that is such a great description of it. So if you see somebody who, you can kind of see this here, this guy has some dry, flaky skin running across his nose, and it is on that erythematous face. Sometimes that scale can look yellow or greasy. It can be itchy, but isn't always. You see it a lot of times on the scalp, the eyelids, eyebrows, ears, around the nose here like this guy has, in the mustache and in the beard. So differential diagnoses to this are psoriasis, which we will talk about in a little bit, rosacea, which we will also talk about, and impetigo, because sometimes these can get pretty inflamed and look like a secondary infection there, or even contact dermatitis can look similar. So this is treated with an antifungal shampoo, ketoconazole 2%. It's pretty inexpensive. It's available in that generic form. So patients are told to wash their hair with this. If it is happening in their eyebrows or in their beard and mustache, they can put it right in those areas as well. They need to leave it in contact with their skin for 10 minutes before they rinse it off. And that 10 minutes is really important. So I will oftentimes tell patients just wet their hair down at the sink, put that shampoo on, set a timer for 10 minutes, and then rinse it off. You can use topical steroids if it's real inflamed or you're having trouble with just using the shampoo. So for the scalp, this is a one time where we go away from our ointment. We recommend a solution for the scalp, or a foam base, which looks more like a hair mousse, and that absorbs really well into the scalp. So for the scalp, we do recommend the fluocinolone or clobetasol, so the mid to even high potency for those areas. For the face or ears, then we recommend the triamcinolone ointment, and you can pair that with ketoconazole cream, layering one and the other one right over the top. So the triamcinolone with ketoconazole right over the top. Order of it makes no difference. They could use the ketoconazole first and then the triamcinolone, and they can do that for up to 2 weeks if they're having a bad flare. So stasis dermatitis is something that we can see in our older patients. This is, it can be erythema, light brown, yellow discoloration of the lower third of their leg. This is a marker for venous insufficiency. Sometimes they can have eczematous dermatitis with it, like they will have a lot of itching in these areas as well. So the lower third of their legs are discolored. They can be dry, scaly, sometimes weepy if it's infected, lichenified, and they can get ulcerations in these areas. The blood supply is not good, so if they're scratching at them, it really sets up a bad situation for the patient. So we treat this a couple different ways. We need to treat the venous insufficiency, so sometimes referring to a vascular surgeon, but most often it's compression stockings. People do not like them. They are hard to get on, but they work wonders. I didn't put it in the PowerPoint here, but there is a company that you can order stockings called EdemaWear. It's EDEMAWEAR. They look like fishnet stockings, and they go up to the knee or they can go up to the thigh. It's $30 for a pair, so they are much more affordable than the traditional compression stockings. They are so much easier to get on because of that fishnet. The patients can get their hands in them, pull them up, and they work really well. So they can order them online or they can call a phone number to order them. We have much better success getting patients to wear those than regular compression stockings. It does leave that fishnet impression on their leg, but it works really well. So topical steroids can be used to help with itching for these areas, and we oftentimes will mix them together with like the clobetasol solution mixed with Cetaphil cream. We'll prescribe for a bottle of the clobetasol solution, and then we have the patients buy a 1 pound jar of Cetaphil cream. They'll actually just squirt that whole bottle right into the Cetaphil cream, stir it up with a tongue blade, and they have it all mixed nicely. Pharmacies used to mix it for us, and now they want to charge you a couple $100 to mix it. So the patients can do that themselves, and they can put that on once or twice a day as needed for the itching. So we recommend putting that on, and then their compression stockings or EdemaWear over the top. And these are just some of the color changes that you can see. This light brownish color that's occurring there. That will never get back to normal. So if somebody is looking for that result, they will not get that. So make sure you have good education with your patient. So we'll move into some drug rashes here. So I'm going to talk a little bit about a drug eruption or exanthem. So erythema with small papules is typically how this rash starts, and oftentimes will occur within 2 weeks of a start of medication. I have seen it occur within 3 months of a medication starting, but if you look in literature, they do state it can even occur as late as 6 months after a medication has been started. Sometimes it doesn't even start until a medication was stopped. So if it was an antibiotic that you gave for 10 days, sometimes the rash won't even start until 10 days after the medication has stopped. So if somebody comes in with a rash, it's a really important question to ask. The lesions tend to occur proximally at first, and then they will spread. It is very itchy, and antibiotics are the most common cause, but it can be to any medication, either prescription or over the counter that they're using. The herbal supplements can cause it as well. So a fixed drug eruption is a little bit different. This too can present anywhere on the body, but about half of them occur on the oral or genital mucosa. Usually it is just one lesion, but it can be up to 6 different lesions. It can usually begins as a red patch, evolves into this target lesion. So it actually will look a lot like erythema multiforme, which we are not going to discuss today, but you could Google that if you wanted to see what the difference is.
Where is it on that?
So on this picture, it is right here. It's this hyperpigmented area on the lip. So people who have more pigment on their skin, it can look hyperpigmented versus a red color. But others it will look more red in people who have less pigment in their skin. So fixed drug eruptions are often caused by, we've discussed antibiotics, but analgesics can cause it, muscle relaxants, sedatives, anticonvulsants, antibiotics. This is another example of a fixed drug eruption. So differential diagnoses. You see the list is huge. We oftentimes end up just biopsying the spot to find out what's going on with it. And the pathologist, they can't tell us to what medication is causing it, but when we biopsy it, it will come back as a medication reaction. And so then we start investigating their list of medicines. In dermatology, then we work with their primary care doctor to kind of figure out what medication it may be. So no labs are needed for this. I discussed biopsying the spot. Sometimes what we have done is So sometimes, like when we're working with primary care doctors, all medications, if possible, are stopped, and then we start slowly adding them back in one at a time. Kind of re-challenge the medications to see if they develop that spot again. So you can treat that with antihistamines. So if somebody comes in and that spot is really itchy, they can take some Claritin or Zyrtec, topical steroids, but the biggest thing is to find out what the medication is and stop it if it hasn't already been stopped. So on the picture here, you can see the hyperpigmented area on the lower lip, and then a blister type eruption over on the right. So now we're going to move into different eruptions, papulosquamous eruptions. So we'll discuss pityriasis rosea in this section as well as psoriasis. So pityriasis rosea, it's likely a viral rash, and I actually had it in the viral rash section and then moved it over to the papulosquamous. We don't know exactly what causes pityriasis rosea, but we believe it probably is a virus. This is a salmon-colored papular and macular rash. It's discrete at first, but then can spread. It often begins with a single patch called the Herald patch, and this is really important for the pityriasis rosea. Patients will come in, and lots of times on their abdomen will say, gosh, I had this spot here for 2 weeks, and now I'm getting all sorts of spots. The Herald patch is usually larger than the other lesions, usually on the torso, so abdomen or back. Once that Herald patch starts to fade, then the new lesions will start to develop. And this eruption can last for 3 to 8 weeks. In some people, it doesn't bother them at all. It's not itchy, not bothersome. Other people, it is very itchy. So it's most common in people ages 15 to 40. Women are affected more often than men. And we see it in the spring and fall. I saw our first case about 3 weeks ago. So I let the other providers in our office know we saw the pityriasis rosea, start looking for it. It can look like secondary syphilis. So in some literature, it will talk about checking an RPR on patients who present with pityriasis rosea. We recommend it for all of our patients. I say about half of them will actually get an RPR drawn. Secondary syphilis is easily treated, but if it progresses, it's not so easily treated. So like I said, I've been working in dermatology for 14 years. Over the last 2 years, we have seen probably 5 cases of syphilis. So we haven't seen any for quite a few years, but it is around, so we need to be thinking about that. So this is a great picture of pityriasis rosea. I love this photo. This here is our Herald patch, our first one that came about, and then all of a sudden all these little lesions coming. So differential diagnosis for this, we discussed the secondary syphilis. It can look like psoriasis. Our Herald patch here has some of the erythema and scaling and thickening. It maybe even looks a little bit like ringworm, the tinea corporis, which we'll discuss in a little bit. And also that Herald patch looks a little like our fixed drug eruption, so that's also on my mind. And a viral exanthem. So treatment of pityriasis rosea, none is required, so if they aren't bothered by it, just the good education within 8 weeks it will go away. If it is itchy, narrow band light treatments are what's recommended. This isn't tanning bed exposure. This is narrow band UVB. It is done in a medical office, or topical steroids can be helpful. So psoriasis. Now this is a chronic inflammatory recurrent disease of the skin. It's considered a hyperproliferative disorder, so it has some connection with the immune system. It is believed to be overactivity of the immune system, and the skin cells just kind of keep growing and growing and thickening up that skin there. It is circumscribed, dry, scaling plaque. 3.2% of people in the United States have psoriasis. It can be associated with psoriatic arthritis, which can be debilitating to these people. These lesions are typically covered with a silvery white scale, and it's really interesting, but psoriasis is typically symmetrical. If it's happening on their right elbow, it's also on the left elbow. It can also itch or burn. So early lesions oftentimes start as an erythematous small macule. They could, if you examine them real close, have a dry silvery scale. These macules will then start to enlarge. They will start to raise, forming papules, and they'll coalesce or join and form plaques. Nails can be involved where they have pitting in the nails, and we already discussed the possibility of psoriatic arthritis. So if someone comes in with psoriasis, you'll make sure you're asking them about joint pain. Psoriasis is much more than just a skin disease, and I hope you will remember that when you're treating psoriatic patients. They have an increased risk of lymphoma, heart disease, type 2 diabetes, obesity, metabolic syndrome. Psoriasis has also been linked to depression, suicide, increased alcohol consumption, and smoking. The annual cost of psoriasis in the United States in 2013 was $113 billion. It is a big disease. You'll see lots of ads on TV now talking about new medications to treat it. But it really impacts these people and their lives. They try to cover. Differential diagnoses include seborrheic dermatitis. The pityriasis rosea can look a lot like it, eczema or lichen planus. So treatment. So at a primary care office, what is typically treated with is just topically. So calcipotriene, which is a vitamin D derivative, it's available in an ointment, cream, and solution. This can be used daily and ongoing, so they don't have to stop after 2 weeks. It's safe to use with a topical steroid and actually has better response rates if you use it with a topical steroid. So topical steroids for psoriasis include the mid to high potency, the halobetasol, furosemide, clobetasol. These to be used everywhere except the face and groin. The twice a day for 2 weeks. We're kind of in that routine. That's what we do with our steroids. And the ointment form is preferred to solution. Compliance is huge for these patients. Psoriasis is usually a lifelong disease where they have flares and then it gets better. These patients are sick and tired of treating these spots. They have to use 2 creams twice a day for 2 weeks, and they can get rid of the steroid and keep up with the calcipotriene. It's really a hassle for them. So if you're treating someone, they're maybe not compliant or the topical treatments just aren't working, then referral to dermatology is really important because we have other things we can do. There's oral methotrexate, narrowband UVB light treatments, and what's being seen on TV is all these biologic medications that have come out, Enbrel, Humira, Cosentyx. Those are big-time medications. They reduce the patient's immune response to help with the psoriasis. It can work very well. Cost of those medications are anywhere from $30,000 to $60,000 a year. And they also have increased risk of lymphomas and serious infections when they're on those medications.
Do they work well? You see all this advertisement on TV.
They do work very well. And they help the psoriatic arthritis.
Are you getting kickback from
So there's a stepwise approach. So the Enbrel and Humira have been around the longest. So those are the ones that we have to try first. And usually what we see with the biologics is patients are on them for a number of years, and then all of a sudden that becomes ineffective. So we have to move it to something else. Yeah. The newest ones that are coming out actually show response rates of close to 80%, which is pretty darn good. So gut tape psoriasis. This is a psoriasis that can happen when somebody is exposed to strep. So lesions will develop following acute infection, usually the strep throat. They have 2 to 5 millimeter sized lesions which resemble water droplets. It usually affects people under the age of 30. We don't usually see it once you hit that age. Responds well to narrowband light treatments. I'm sorry, that was another typo there. But when somebody comes in and we're suspecting it, we will check a throat culture and also an ASO titer. If these are positive, we treat that strep infection even if it's late, and then we start treatment of the gut tape psoriasis. So fungal infections, ringworm and tinea versicolor, what we're going to discuss. So fungal infections of the skin present with erythematous, dry, scaly patches, which usually have central clearing, which is different from our atopic dermatitis and some of our other rashes that we've already discussed. As this stays on people's skin, the lesions get wider and bigger. It's really common in wrestlers. So if this is somebody who has had a fungal infection, I would maybe even say for years. So she's clear in the center. It actually looks a lot like her normal skin. But you can see this red border. So the fungal infection just keeps moving out is what happens. If we were able to magnify that, it would actually look kind of dry and scaly when you got closer to that rash. So this is kind of like our warts, where depending on where they're at, depends on what you call it. So tinea capitis is when you have a fungal infection of the scalp. Tinea barbae is the beard. Tinea corporis is the body. Tinea manum is the hands. Tinea curis, or jock itch, or the groin, and tinea pedis is your athlete's foot, or the fungal infection on the feet. So definitive diagnosis isn't possible in all offices because you have to have a microscope to have a definitive diagnosis, but that is the KOH prep that we discussed in our procedures workshop. So you would take a scraping from right along on this border here with your microscope slide, scrape some of that skin on there, put your cover slip on and your KOH over the top, and look under the microscope for the branching hyphae. So differential diagnoses are pityriasis rosea. That looks a lot like a hero patch there. Impetigo, dermatitis, or even psoriasis. We treat it with antifungals. There are so many antifungals. There's great ones over the counter even that work very well. The thing is to just use it long enough. So twice a day for 2 to 4 weeks. If we have somebody that doesn't have good insurance coverage, we'll just tell them to get some clotrimazole over the counter. Use that twice a day for 4 weeks. There are some newer ones that are available that can treat for a week, but again, that comes with lots of cost, and most insurance companies will not cover those medications. So tinea versicolor is a type of fungal infection that typically develops on the torso or the upper arms. It is caused by a specific fungus there. It is more common during the summer months, and usually because people are outside, the rest of their skin's getting a deeper color to it, and the fungal infection now stands out more. It can be itchy, but most of the time is not itchy at all. And diagnosis of this is really just by how it looks. So I have some photos here which shows it looking more like an erythematous rash. We're going to see some other photos later which will show sometimes instead of that pinkish or reddish color, it can look a deeper brown color. So on this patient now, somebody who probably had a good tan going, and the spots just tend to stand out. So sometimes they look a little pink, but sometimes they just look like lighter colored skin. That's all in these areas. So differentials for our tinea versicolor are again pityriasis rosea. It does look similar to that. Seborrheic derm, vitiligo, or even pityriasis alba. So with our tinea versicolor, when we're suspecting it, we go ahead and treat it like it's tinea versicolor. And then if they don't respond, we have them come back and investigate what else it might be. So selenium sulfide lotion is available, but this is kind of hard for the patients to use. It's inconvenient. It can be treated really well and pretty cheaply with oral fluconazole, 200 milligrams, so our diflucan is the brand name. So they take 2 pills on the day they come into your office. 1 week later, they repeat that, and then they repeat it again in 1 month. That usually gets rid of the infection for them. But once somebody has tinea versicolor, it is likely to recur. Maybe next summer, maybe 2 summers down the road, they'll get it again. We'll talk a little bit about insect bites and bug bites. So this includes scabies, bed bugs, tick bites, and lice. So scabies are caused by Sarcoptes scabies and itch mite. A fertilized female burrows into the stratum corneum. She deposits her eggs. They develop then into pruritic papular lesions and burrows. Scabies is spread through close contact, and it has intense itching that is really worse at night. I know we discussed earlier with rashes and itching being worse at night. This scabies, though, will keep people up. They won't sleep because they are going to be scratching so much in the evening. So common areas infected are finger webs, the wrists, ankles, axillae, umbilicus, lower abdomen, genitals, and buttock. And these are some great pictures of burrows from the scabies. And I just want a quick note for genitalia. So scrotum in men, lots of times we have gotten referrals for patients that have been treated repeatedly for jock itch. It wasn't jock itch, it was scabies. And we see that probably once a year where this poor man has been scratching and itching for quite a while. So definitive diagnosis is with the scabies prep. We discussed that in our procedures workshop as well. It's really simple to do, but you have to have a microscope. So then treating it with permethrin 5% cream, where you scrub it on your skin from your neck to your feet, wash it off 8 to 10 hours later, and then you have to retreat. Ivermectin is a really nice oral antifungal that can work. It's much easier to use, and then you repeat it 1 week later. Everybody in close contact needs to be treated. Clothing and bedding needs to get washed, your stuffed animals, anything that might be there. Pillows need to be bagged or washed, and people can get lots of itching after scabies. There lots of times get worried scabies is back. Very uncommon that they get a repeat infection unless they haven't properly laundered everything. So bed bugs, see more and more of these little guys around. They can occur anywhere. They live in old furniture, seams and folds of mattresses, bed frames and springs. It affects anybody of any age or sex, but it is more common in poor areas. Typically, they bite people at night. So repeated bites can cause more and more of a reaction in people. As an erythematous papule, sometimes a welt develops or bite reaction, 1 to 2 millimeters in size. They're very itchy. They may form into a blister or bullseye. And 3 to 4 linear bites in a row is pretty diagnostic for these bed bugs. And I don't know if you can see it much on this photo here, but it's called the breakfast, lunch, and supper. These 3 bites right in a row, and you do see that. So treatment is with topical steroids. So once the bites are there, we just have to help bring down the inflammation and help them go away. But more important, where did they get them? So extermination by professionals in their home. But if they have recently traveled, lots of times they pick it up at hotel rooms. We oftentimes will just tell our patients, make sure that your suitcases are shut and zippered, and the bed bugs can't get into your suitcases. Lots of times we'll put that on the floor, and those bed bugs can move in there. Tick bite. So Wisconsin has 2 main ticks that bite humans, the deer tick and the wood tick. And I have some photos of them here, of course, magnified. So oftentimes they're just an annoyance. You remove the tick, got to be careful that you do remove the whole tick, or the remnants can stay in there. But the deer tick, if that is suspected, you need to check a line titer. The ticks can cause diseases such as Lyme's disease. And when I was checking on the CDC, specifically for the state of Wisconsin, I saw these other diseases that can be caused by ticks in Wisconsin. Now, I don't know much about the other diseases. I think that would probably be more infectious disease, but it was just interesting to me to see that these other diseases are found in our state. So lice, I just show a few pictures here. It is very, very rare in adults. So I'm not going to discuss it much here, but we do talk about it in the pediatric lecture. I've actually never seen it in an adult. So skin infection, cellulitis, and impetigo. So cellulitis is a proliferative infection of the subcutaneous tissue. It's usually caused by the 2 listed above there. So it usually starts with a wound. There has to be a portal of entry for that bacteria to get in. And symptoms include local erythema, tenderness, malaise, chills, and fever. And the erythema can spread quickly. The area can get infiltrated. You can see that patient's left leg almost looks like that skin just wants to burst open. They can have pitting edema, streaks of the lymphangitis, and gangrene or sepsis may occur, but that's pretty uncommon. So treatment of the area, somebody came into your office with this, you definitely want to culture that area and start an empiric treatment on somebody like this, and maybe even give her something more. You can see the streaks of lymphangitis here. Depending on your office, you'd maybe want to start some IV antibiotics or an IM. But you always get the culture before antibiotics are started so that you can direct treatment. That can take 48 to 72 hours to get the culture back. So if somebody started on your penicillins or the cephalosporins and no response, you want to consider the possibility of MRSA. Impetigo, again, this is discussed more in our pediatric lecture, but just a nice photo of the honey-crusted lesions here.
You know, but maybe it does cover adolescents, so that's something that they deal with.
Yep.
In the adult population, so.
I just didn't want to repeat things that they're going to get in the next lecture.
Okay.
So I tried to, I tried to be careful to not repeat things that are going to, I know they'll see the video of that as well. So acne type eruptions. We're going to talk about rosacea, perioral dermatitis, as well as regular acne. So rosacea is persistent erythema of the face, typically of the cheeks, nose, chin, and glabella. The periocular skin, so that's the skin surrounding the eyes here, is usually spared. It is most common in light-skinned women, ages 30 to 50. We can see severe rhinophyma in elderly males. That's the bulbous nose that can develop. And it's actually, if you've never seen somebody with it, it's really spongy even when you touch that there. It doesn't happen in females often at all. And we don't know exactly what causes it, but sun damage appears to play a big role in it, as well as genetic factors. So for rosacea, when somebody's presenting with it, it looks like some telangiectasias of the face. People will talk about redness, flushing, and they can have papules or pustules, but they don't always have it. So triggers to it are stress, hot drinks or food, spicy food, alcohol, exercise, temperature extremes, or and then the hot bath and shower kind of going along with the temperature extremes. So differential diagnosis include lupus or connective tissue diseases. This photo here is of the rhinophyma. You can see the bulbous nose on this person. So you're going to treat it first with some topical products. There are some great things out there. The metronidazole has a gel that's available generic. It's pretty inexpensive where patients use that once or twice a day. Tretinoin is an acne type cream that can work very well. To get coverage for this in an adult is difficult because tretinoin also helps with fine lines and wrinklings. Lots of insurance companies don't want to cover that because they consider it cosmetic. And Soolantra is a newer product that's available to help treat rosacea. It has been around for about 2 years now, but we have not seen good results with the Soolantra, and it's very expensive. So oral antibiotics, if somebody's coming in with the papules and pustules, sometimes the metronidazole isn't quite enough. So we will treat with tetracycline family and a very low dose. So doxycycline, when you're treating a bacterial infection, you're going to be using 100 milligrams twice a day. When we treat somebody with rosacea, that dose is below 50 milligrams, so it's 25 to 50 milligrams one time a day. So it's well below the antimicrobial levels. With that being such a low dose, we don't worry so much about the possibility of resistance. And we've just seen with the rosacea, we don't need high dose antibiotics to help with it. Other treatments can be done with referral to dermatology or plastic surgery with laser, surgical procedures. But big things are prevention, so wearing sunscreens and trying to avoid triggers when possible. So acne, We also have acne in adults. It is treated the same as what we treated in our teenage population. And I don't think I go into it much here because again, it's discussed quite a bit in that pediatric derm lecture, but very similar to our rosacea where we do use topical retinoids such as the tretinoin and then some type of antibiotic, either topical or oral antibiotics as well. So our perioral dermatitis is something that you'll see quite a bit in primary care. It's a perioral eruption. So if you just took your fingers and circled from the bottom of your nose down around your chin, right here, it looks like acne. People come in and they have real discrete papules and pustules. It can be on an erythematous base. Sometimes causes burning or itching. Usually affects women between the ages of 20 to 50. So they'll come in and say, I've never had acne. Now I have these breakouts. I can't get rid of them. It may be related to toothpaste, or sometimes people will put like a topical steroid on their face, which can cause it. But most often we don't know what causes it. We do know that once they have it, if they do put a topical steroid on there, which a lot of people will come in and say, I put some hydrocortisone on it, it's going to make it worse. So these are some typical looking rashes for the perioral dermatitis, and we have them stop topical steroids if they're using it. We treat it with usually minocycline or doxycycline. They're both dosed the same, the 100 milligrams twice a day for a full month, and then they will decrease it to once a day for 2 weeks. So it's 6 weeks of antibiotic, which seems like a long time, but it will recur quickly if they don't take it for the 6 weeks. And when somebody has this, it's kind of like the tinea versicolor. They are more likely to get it again, maybe a year from now, maybe 2 years from now, where they'll have it again. So these women look like they've had it for quite a while before they came in. And I just make one other note about perioral dermatitis. You can also see it around the eyes in a periocular distribution where it looks that same way. Right, this is the end of part 1 dermatology.